As parents, we all get super excited when we go in to get our first fetal ultrasound. But what happens if that ultrasound technician finds something abnormal with a vital organ, an organ as vital as the heart? Where do you turn? I'm Dr. Nate Kuppermann, Chair of Pediatrics and Chief Academic Officer here at Children's National. I'm a pediatric emergency physician, and I've spent 3 decades caring for acutely sick children, including those that have these cardiac crises. There's about 40,000 children born each year in the United States with congenital heart disease. And my job in the emergency department is to stabilize them and then pass them over to my colleagues in cardiology and cardiac surgery. But then what happens? I'd like to welcome to the show Drs. Wayne Franklin and Mary Donofrio, 2 of our leading cardiologists here at Children's National. Thank you both so much for being here.
Thank you.
Thanks, Nate.
I'd like to quickly introduce you guys for our listeners. So Dr. Wayne Franklin, who I'm going to call Wayne, is the director of our Heart Center. He comes to us from Phoenix Children's, arrived here at Children's National kind of similar in time as I did last year, has lots of areas of expertise in pediatric cardiology, including single ventricle, Fontan physiology, pulmonary hypertension, cardiac disease and pregnancy, amongst a number of other things. And Dr. Mary Donofrio, who I'm going to refer to as Mary, is an international expert in fetal cardiology, is the director of our Prenatal Cardiology Program, super well known as a national and international researcher with more than 150 publications, NIH grants, and the lead author of a really important AHA guidelines on the diagnosis and treatment of prenatal cardiac problems. So welcome to you both.
Thank you.
Thank you.
But before we start, I just want to raise one thing. So Wayne and I are relatively new to DC. We've been here just a few months. We've eaten together a couple of times, but we're just sort of wandering in the darkness, trying to find a good place to eat. So Mary, as the seasoned, experienced Washingtonian here, do you have some advice for us about where to eat?
What a great question. And I would say there's not a bad place to eat. I think Washington, what I love about it is it's very diverse. There are so many cultures and ethnicities that you can really get anything. So my advice to you is to be bold.
Okay.
And try something new.
And what is your favorite, by the way? What favorite ethnicity of food?
Well, of course, Italian, since that's my heritage. And there are many good Italian restaurants. But certainly Middle Eastern, Spanish tapas is very good here. So many great options.
Sounds pretty good, Wayne.
I mean, I'll eat anything, so that sounds fine. That sounds fine. I mean, you could go high end, like Michelin star. You can go regular diner. I'm just as happy.
Excellent.
Sounds good.
Great. So, hey, so let's get into it here, and I'm going to start with you first, Mary. Just first of all, how did you get into your field? Just give us a little bit of the background on that.
I think the big question for my family is how did I even decide I wanted to be a doctor? There were no doctors in the family. And from the time I was a little girl, I just wanted to be a doctor. And in med school, I think the heart actually fascinated me. It is amazing. It is perhaps the hardest worker in the body. It's the first thing to start. It's that gives us life, and it's the last thing to stop when we die. And so I really found the heart and pump physiology fascinating. When I finished, I knew I wanted to be a cardiologist. I didn't really enjoy taking care of the grown-ups, I have to say, and fell into pediatric cardiology, which I thought was just an amazing field to be able to help kids right from the beginning. And then fetal really didn't exist when I trained. And my first job was as an imager as head of what we call the Echo Lab. And my boss said, I want you to start doing this new thing called fetal cardiology. So I went and I trained with actually a world expert. He was considered the father of fetal cardiology at Yale, and really had the opportunity to learn from a master and also work with obstetricians. And it was amazing taking care of the women during a really tough point in their life and being with the babies at the beginning of their journey. So what a great field to have fallen into. And I can't imagine having done anything else.
So you actually knew as a child, not only that you wanted to be a doctor, but you wanted to be a cardiologist. Is that what you're saying?
No,
no.
the cardiology
That
part came later. Yeah.
Got it.
Yeah.
Okay, and let me just ask you, since you raised calling it the most important organ, I struggle between the brain and the heart, and we'll be talking about that a little bit later.
Yeah.
Ponder that one.
I will ponder that.
Yeah, okay. 'Cause we'll come back to that.
You can't live without your heart.
Yeah.
I'll just say that.
That is true.
Right.
That is true. So
I'll leave that one alone.
So,
That's good.
So Wayne, I'm going to ask you a similar question. I also want to know how you got into pediatric cardiology, but also give us a little bit of the global perspective about pediatric cardiology and the science around pediatric cardiology and how it sort of expresses itself at Children's National.
So I initially got into healthcare. My dad was a doctor, and so he's a neonatologist, and so I was always surrounded by it. Then I went to medical school, but it wasn't until I got into residency, and I remember I was on call one night in the cardiac ICU, and I was a med peds resident. This adult cardiology fellow came crashing through the doors. He just put a stent in this patient and saved the guy's life, and I was like, I want to be that guy. I thought that was so cool. And it just, it was the time when, healthcare was really on the way up and everything. And so I just kind of followed in his footsteps. It turns out that guy's name was Wayne as well. So that was like a natural fit. But and we're actually still friends today, and our wives are friends. So he's been a great role model for me. And then, cardiology, to Mary's point, so interesting. We can do things with drugs and medicine. We can do things with surgery. We can do things with minimally invasive things with catheters, just through blood vessels. And so to be able to do that in one field is fantastic. The field of pediatric cardiology, I mean, the sky's the limit. I'm actually really excited. I know Mary is too, with the research potential that we have and the progress that we've made. If you really look at pediatric cardiology and congenital heart disease, it's a relatively young field, but it's an amazing field because back before, 80 years ago, 1940s or so, most or all these kids would die. And now we've essentially reversed that trend where most of them are surviving to adulthood with some big impactful advances that we've made. And so that to me has really shown the impact of both science, surgery, medicine, and really just some great planning by a lot of the experts in the field.
It raises kind of two things for me. First of all, the power of early examples and mentorship, right? We're really struck by people that we admire as trainees and whatnot, and they have the incredible potential to help direct our direction in terms of where we go. And that sounds like partly how you got there. The other thing I was going to say, as a pediatric emergency physician, I've resuscitated a lot of children with cardiac disease and then hand them off to you guys, to the pediatric cardiologists or the cardiac surgeons, and then I move on to the next patient, and I never get to really know exactly what happens. Part of the joy of this particular session with you guys is that I get to learn some of the things that happen after that handoff. So I'm going to go back to you, Mary. I know we mentioned just in the opening, you were the lead author of these important AHA guidelines about the diagnosis and treatment of the fetus with cardiac abnormalities. Why don't you just take us through that and tell us where that has gone?
Well, thank you for that question. Certainly, writing the guidelines with a group of 19 experts was certainly a highlight of my career. It took 4 years. We joke about that from the time of conception to delivery was a really long time, and that was our labor. So it was certainly a long labor, but the result is really something we're all very proud of. These guidelines are used nationally and internationally and have been translated into Japanese, for example, which was really amazing to see. The guidelines, they cover every area of fetal cardiology. So things like who should get tested. That's the indications, who are the highest risk women. And then once you do get testing, what kind of testing do we do? Our mainstay is ultrasound called echocardiography, but there's also other more advanced testing that we can do, like MRI, for example. From there, we talk about how to care for fetuses. So how do we follow them in utero? How do things progress? Who do we have to worry about? I created a protocol where we could use ultrasound to identify those at risk and then plan who needed specialized delivery room care. And we tested it right here in Washington, and then first wrote about it after 8 years of experience with it, and really showed that it worked. And so that was then carried to be part of the guidelines, which now are used everywhere.
This issue of risk stratification, this is something that as physicians we all do, and for our listeners, that's identifying which children or which patients are high risk, need immediate care, need immediate referral, versus those that can be referred later, etc. Are there other tools that you use beside the echocardiogram, besides the ultrasound? How do you do that risk stratification?
We've used fetal MRI for years, and I've worked with our radiology colleagues, an expert in the field herself, to really look at the rest of the body, look at the brain, look at the lungs. And the lungs are very important as you transition from fetus to baby. And so we spend a lot of time together sort of trying to understand how the other parts of the body beyond the heart will affect what's going to happen in the delivery room. In addition, we are developing fetal EKG technology, and that's right here at Children's as well, where we're working with our researchers to develop that technology. So hopefully we'll be able to understand the rhythm better, because that certainly can make babies sick in the delivery room as well.
Great. And actually, it sort of leads to another question. As I mentioned at the start of our session here, that about 40,000 children are born each year in the United States with congenital heart disease. And now with all this great new technology, about 3/4 of them are diagnosed in utero. It does still leave a quarter who are not. So what happens to those infants that are not diagnosed prenatally? First of all, why does that happen? And then what happens to them?
I think if you look at the data, yes, in our region, we have about a 60 to 70% detection rate. So if you look at babies born in our intensive care unit, about 3/4 of them, as you said, are prenatally diagnosed. But in other parts of our country, that's not true. And detection can be as low as 20 or 25%. We participated in study. We actually led the study here at Children's through an organization called the Fetal Heart Society, which is an international research collaborative that I was the founding president. So we started this in 2014 to really try to bring together researchers to answer these hard questions. And the first publication was from our group, where we looked at barriers to detection and certainly found that things like socioeconomic status, ethnicity, all played a role in detection, as well as distance from the tertiary care hospital. So if you lived in rural areas. A follow-up study that one of our fellows did, who's now one of our attendings, was to use census data to identify hotspots where detection was less, even in our community, so in the DC area. And so now with this information, we can go into these communities to help them. What do they need? Do they need teaching, or do they need ultrasound equipment, or us to set up a clinic? And so it's enabled us to then increase our reach to hopefully improve detection even within our region. And so to be able to identify those babies and to set up protocols where we can initiate care really matters. What we're looking to do is to certainly prevent a baby from dying before they make it to us. But other important things If a baby is born with a low oxygen level, it can affect their brain, it can affect their kidneys. And so, as we try to improve the overall outcome, which includes what we call neurodevelopment, we want to make sure these babies do well right from the start.
It's interesting. I'm going to get to this question of the brain and neurodevelopment, but one thing that this brings up when we're talking about pediatric subspecialties in general, and pediatric cardiology is just like that. There's not enough pediatric subspecialists in this country to reach every remote corner. True in pediatric emergency medicine, my specialty. And it raises an important question. I'll be asking Wayne this question as well as, wow, how do we get our expertise that we have in the big pediatric centers? How do we get it so it reaches every child in the country, much less every child in the world? That is really a challenge facing all pediatric subspecialties, but the ones that are really deal with acute care where you don't have time to refer somebody, and that is really an important challenge. But I want to get back to the second thing that you had mentioned about neurodevelopment before I transition to you, Wayne. So we started by talking about what's the most important organ, brain or heart? I don't know. I have no skin in the game because I take care of all the organs. Okay, but just talk a little bit about neurodevelopment. How do you think about the developing fetal brain vis-a-vis the heart, and how do you monitor and whatnot?
It's actually been my research interest since the beginning. I still think the heart's the most important, but certainly, as Wayne said, our patients are now living. And when I first started, we were just happy to get them out of the intensive care unit. And now our expectations is that they will become grown-ups. And most of them are. And to me, that is the most powerful thing, to want to do better. And so what we know is these kids become grown-ups, as many of them will have difficulties in school. And the question is why? Why is that? And the answer is actually that there are multiple points in a kid's life that are critical to the brain. And it's important for us to think about the brain, because certainly what makes grown-ups happy and successful is to get through school, to get a job, and to be able to live independently. So we want that for all of our kids to reach their full potential. What we've learned is that it starts in the fetus, that the way the blood moves through the body into the brain can affect the way the brain develops. There is a lot of research going on at Children's to try to understand this using very fancy technology with MRI. And then certainly the delivery is another important time point, as we talked about, making sure the brain gets the blood flow that it needs. Surgery is important, protecting the brain, that's neuroprotection. And our group is doing a lot of research in that area, how to protect the brain during the actual operation. What I am most proud of, though, is in 2010, one of our neuropsychologists and I started a program that's called our Cardiac Neurodevelopmental Outcome Program, or CAN-DO. And what this program is to assess our children from their birth, so right in the intensive care unit, looking at risk factors for neurodevelopmental outcome, to make repeat assessments, and including in the outpatient setting. We follow them from birth until they're adults. My favorite part of it is called school readiness testing, which when these kids are between 4 and 6 years old, a neuropsychologist assesses these kids and then can give families and schools advice on what kind of a learner a kid is and how to really maximize their potential. So, until we figure out why this happens, to prevent that very fragile brain from being affected, the Cardiac Neurodevelopmental Outcome Program, I think, will give every kid that we take care of a head start and the help that they need.
Great. So, Wayne, I'm going to turn to you and first of all ask you, what do you think? And what I'd like you to address, since you're sort of one of your main focus areas is in the ICU, how do we do neuroprotection? That is, protecting the brain in the operating room, in the ICU. What are your thoughts on this topic?
Yeah, one of the things that our surgical colleagues have shown now is that the way they do the operation and how much time it takes is directly correlated to outcomes, right? There's a sort of the old axiom, which is time is tissue, right? We used to think that was strictly for cardiology. We also know it's related to the brain too. And if the brain becomes ischemic, we know that's a problem. So not only do our surgeons need to be facile and relatively quick with their operation, but they also have to be thinking about what does the perfusion to the brain look like? Can they do different temperature regulations? Can they give different additives that might lead to better neuro outcomes the way they did neuroprotection during the operation? And then post-op, in the ICU, to your point, Nate, we were talking about, what does cardiac intensive care look like? It is its own subfield now, right? We know that it's sort of a field outside of just regular pediatric critical care, pediatric cardiac critical care. So important. To Mary's point, the way that, as we say in cardiology, the way the blood flows, really important. And the way that the surgeons operate and they actually will change the blood flow, hopefully to something more sustainable, is really impactful. And so to be an intensive care doc, you have to know all of that. And so there are certain ways that we monitor these patients. We're very blessed to have a telecommand center in our hospital, Children's National, that we sort of say there's a lot of command centers around the Washington, D.C. area, and this is ours. Might be a little smaller, but hopefully just as effective. And so we're watching every baby, every day, every heartbeat, every breath is being monitored by experts, by physicians, nurses in the command center, so we can try to predict if there's going to be a problem, predict deterioration or decompensation. And a lot of our outcomes and a lot of our data have shown that if we can make certain tweaks or changes or, things about even dressing changes or rotating a child or changing a central line, we know that definitely leads to outcomes that are beneficial. And so we use all of those data in a sort of data analytic way to address outcomes. It's a really exciting time because, the whole catchphrase AI, artificial intelligence, which I actually try to think it's more of like augmented intelligence. It's not artificial because it's really happening in our ICU. And so we're able to incorporate a lot of that and translate that right to the care of the patient.
The way I think about it in my simplistic version of how these children with congenital heart defects present to Children's National and hospitals like ours. So if they're diagnosed in utero and the physicians know they're going to be sick, the umbilical cord is clamped, cut, patient's handed off to cardiologist, cardiac surgeon. That's one way. Another way is you can make the diagnosis of a stable child with a defect, and then they get referred, but not emergently. And then there's the patients that I deal with in the emergency department. They're frequently perhaps those children that are not diagnosed in utero, and they present in emergency departments, and you either in fulminant cardiac crisis or they have some red flags that make you think, wow, this kid is going to decompensate, get real sick. So then those patients, we turn them over to you in the ICU. So I'm going to go back to something you said. You gave a nice overview, but you want to just walk through for our listeners, what does it look like in a pediatric cardiac ICU? What do you see? And talk a little bit more about how we use AI to improve care, how we use monitoring, all those things, just to give a good visual for our listeners.
It is, I think, the most challenging area because we're dealing with sometimes the smallest patients, right? Talking about newborns. And sometimes we have large patients, teenagers, young adults who also have congenital heart disease. And these are all done at Children's National. So when you go into our pediatric cardiac ICU, as we call it, CICU, SICU for short, it's a conglomeration of all these teams working together. So we have cardiac intensivists, we have cardiologists, we have fetal cardiologists, we have surgeons, residents, fellows, and we're really, Nate, bringing all that in together to care for one patient at a time. But it takes a team of sometimes 18 people in one rounding bedside. We're looking at all the vital signs. We're looking at oxygen saturation, blood pressure, urine output, neuro-infrared spectroscopy, NIRS monitoring, all of that to be able to decide what's the next best step for the patient. Should they have an operation? Should they go to the catheterization lab? Should they get a CT? Should we just let the baby recover, right? By the way, a lot of times we're dealing with fresh post-operative cardiac patients who just had major cardiac surgery. So all of that is sort of orchestrated by our intensive care team, and it's really a wonderful place to be, but it's very challenging and it's very stressful. But I think if it goes well, and most of the times it does, then it's really amazing. And if it doesn't go well, our team gets together, we jump in there, and we react. But we try to be proactive and prevent deterioration and illness. But we just have to see what the patient gives us sometimes.
So I want to turn back to the question that I asked Mary about how do we extend this expertise to areas that are distant and remote. And I know at Children's National, we do some remote monitoring of other centers. Do you want to talk about that?
Yeah, this is great. This actually was here when I started here, and they've been doing it for several years now. So we're able to extend our expertise with really, we call it telemedicine, but we've been doing it for several years, even though that phrase has caught on now. And so we every day will be monitoring other children, other patients in other hospitals, sometimes in different states. We're certainly monitoring our 26 beds of ICU patients, but we can also monitor other patients with the doctors at that hospital, and we look at their vital signs. We round with them. We even have a camera, so we're sort of doing visual inspection too of things. And so to be able to do that, Nate, is a way to bring our expertise to remote areas where there's physical barriers, there's geographic barriers we may not be able to get over. And that's been outstanding because I think the receiving hospital likes having our expertise, and we like being able to take care of these babies with the help of the team on the ground there.
And when you're doing this, are you able to interact with families as well, like the families of these patients, or is it strictly with care providers, the physicians?
Mostly it's the care providers there, but if, like us, if they are having the families at the bedside during rounds, which is really standard of care now, they're there as well.
Yeah.
So it's quite beneficial.
This is totally amazing. Again, I started thinking, I just resuscitate the baby and the kid and hand them off to you guys. And it's, the technology has become really amazing. So one last question I want to ask you, Wayne. Again, we're doing AI modeling to figure out who's going to decompensate. We're using all these, teletechnologies. We have these incredible ways to image fetus and infants. What do you anticipate? What do you think is the next big technology that's going to transform how we're taking care of children with cardiac defects?
I'll mention two, I guess. One would be, I think, wearable technologies. I think we need to be able to have patients being monitored at home. I mean, we're doing it very lightly, right? We're checking weights, we're checking feeds, we're checking maybe oxygen saturation. That's fine. But there's so many other vital signs, blood sugar, movement, heart rate, sleep time, that we haven't quite figured out how does that relate to outcomes, right? And so they're doing research to do that, and we want to be part of that. And the other thing I'll tell you, and I think hopefully Mary will agree, is that I'd love to be able to scan more patients, because a lot of what cardiology is diagnosis with an echo, right?
So scan being just to image?
To image. And they're doing this at some places in Europe where they're actually having an echo probe being ran remotely by me 1,000 miles away, telling where the echo probe needs to move on the patient. So that's sort of science fiction, but it's actually being done at some places. So I think we should be able to do that. The last thing I'll say is that we actually can try to educate and teach the parents to do some of this. There was a study out of Stanford looking at teaching parents how to scan echo on their own patient as they're monitoring aortic root size for their patient who's got Marfan syndrome. And you can teach parents to do that, just a couple views that are beamed back to us or to the physician, to then say, okay, that's an adequate study, or no, it's getting too big, you need to bring that patient in. Now, that's trusting the parent with a $100,000 echo machine, but there's smaller versions you can get that can be given to patients. So those things I'd like to see.
Let me follow up with something. I'll ask this kind of to both of you guys, and then I'm going to see if I can synthesize a little bit all this incredible information that you've provided us. Back to AI. So in the emergency department, we use ultrasound a lot, but there is different levels of comfort with ultrasound, particularly if you're putting it in the hands of parents. What's the role of AI? AI helping with the imaging and making the interpretations rather than leaving it up to the clinician or the parent, where there's great variability in the ability to image a number of things. Is there a role for AI in the interpretation?
I do think there is a role for AI, and I like Wayne saying it's all, augmented intelligence, because certainly the machines are only as good as those of us who program them. AI has the ability to recognize key views of the heart. So the 4 chambers of the heart, the 2 arteries that come out, and by repetitive kind of learning, it's called deep learning, that the machine can recognize normal from abnormal. And then once it's tagged abnormal, then a referral is made. And so certainly that's something that we can use, particularly in regions where our reach is distant, that we can't go there. I think the biggest challenge, though, is those regions that need it, is how do we get that technology there? And so that certainly is something that we need to work on.
So I'm going to try to synthesize what you guys have just told me, and you tell me if I have this right. So 40,000 children in the United States are born with congenital cardiac disease. Overall, maybe a quarter of them are diagnosed in utero. Greatly depends on where you live. If you're fortunate to live near a center that can do that, great, but others don't have that good fortune. Some get diagnosed and can be referred. Others can present in critical condition. And when they're in critical condition, they're transferred to a critical care ICU, cardiac ICU, that is. And there we have like amazing new technology, monitoring, ways to identify who's going to do well and who's not going to do well. We monitor to make sure that their brain, the second most important organ of the body, maybe we'll say today, remains healthy as best as we can, both monitoring the fetus and the neonate, and monitoring during surgery in the ICU. And then we have novel, non-invasive ways to treat a lot of these lesions, and who knows what's to come afterwards. Did I sort of summarize that more or less?
That's pretty good for an ER doc.
And I guess, my parting question for you both is, what's the call to action? What do we really need to mobilize to do next to really take this already tremendous frontier of pediatric cardiology just to the next level? And I am going to give a shout out to the great work that we do at Children's National. And we are at the very leading edge of this. And I would love to figure out, how do we get to the next level?
Mary?
Sure, I can start. It does all start with the fetus.
There you go.
There it is. The way to sum it up is we've rebranded ourselves as prenatal pediatricians. And that really is a big thing. What that says is that these are our patients from the time we first diagnose them in utero. So what can we do to improve their outcomes and care for them from the time of diagnosis? Well, the first thing is early diagnosis is very important, and the technology is helping us here. We were one of the first that started looking at the fetus in the first trimester. So at 12 weeks gestation, we can see the heart. The other thing that we can think about is once we diagnose it, particularly if it's early, the genetics of it is very important. And we certainly have an amazing genetics department. The goal would be to identify the genes and maybe cure this at some point. Can there be therapies that are initiated in the first trimester that will prevent the development of congenital heart disease so that no baby is born with congenital heart disease? And then from there, following these babies in utero, we've learned a lot about what happens, how things progress. Wayne mentioned monitors. We give moms monitors to follow the fetal heart rate at home so that they can be a part of the care. So really all of it together is to identify congenital heart disease early, identify it in as many patients as possible, and then really try to figure out a way to either eliminate the heart defect or at least minimize the severity.
Wayne, last word to you.
I'm going to take a global perspective and say research, and without being too political, I think we need to really emphasize the really good pediatric and prenatal research that we're doing, and that it matters, right? I think Nate, I heard that 90% of healthcare dollars are spent in the last 2 years of life, right? The last 2 years of life. But if we can make that 1 or 2 changes, right, in fetal life or in neonatal life, right, to set this baby with heart disease on a different course, that baby is changed forever. And I think we need to get people to understand that and really emphasize that. So I'm calling out to the researchers, I'm calling out to the industry, right? They need to realize that there's a market in pediatrics, there's positive outcomes, it's better for society, and that would be my call to action.
So, Dr. Wayne Franklin, director of our Heart Center, Dr. Mary Donofrio, director of our Prenatal Cardiology Program. Thank you both for being here, for enlightening me, enlightening our audience here in the Lead in Peds.
Thanks, Nate.
Thank you.
Please subscribe to our show wherever you get your podcasts and learn about what we're doing to raise the bar of care for all children here at Children's National and around the world.